am Dr. Rakesh Pandit, Senior Consultant in Internal Medicine and Head of Department at Akash Healthcare, Dwarka. And we will be talking on management of diabetes in old age. And with me is a eminent speaker, Dr. Zargar. Over to Dr. Zargar.
I'm Dr. Abdulhamid Zargar from Srinagar, Jammu and Kashmir, and today we'll be talking about what are the peculiarities of diabetes in old age and what is the role of gliptins, a specific class of drugs, in managing diabetes in this age group.
Dr. Zargar, do you think that the old people, we have to have a different management protocol for old people managing their diabetes?
First, Dr. Pandita, I must tell you, every age apart from the disease has its own peculiarities. A type 2 diabetic at 20 is different from a type 2 diabetic at 40. And a type 2 diabetic at 40 and is different from a type 2 diabetic at 80. Why specifically this has come to the fore that we need to look specifically for management of diabetes in old ages? Now people live longer, and in spite of whatever we say about healthcare, longevity has increased, and this is a global phenomenon. And in fact, from 1947, I think now a couple of decades have been added to life expectancy in the Indian subcontinent as well. As you get older, diabetes does not remain diabetes alone. It comes with a package that happens in the flank simultaneously.
Yes.
And when you are taking care of an issue, you also have to make it sure you do not create an additional issue, right? And if you look at it, today we have on this globe the highest living people who are 65 and above that this planet has ever seen. And there will be a fourfold increase in people who are 80 or above living in the next 2 decades. So that's one reason why we specifically need to talk about management of diabetes in these people.
Unfortunately, we don't have much data of old people where drugs have been studied. All the studies which have been done, they usually recruit people less than 65 years of age, and older people are usually excluded. So whatever experience I think that has been gained from your own clinical practice and day to day what you are seeing, keeping in mind the high risk of older people. And do you have any preference for the drugs? When you select a drug for an older people, do you keep something in mind that I have to be careful of some points which should be avoided in older people?
See, as you very rightly said, as a person gets older, particularly above 65, we have been talking as professionals for the last 3 decades that diabetes comes at an early age, diabetes has become more aggressive, diabetes epidemiology is increasing. But in spite of all those things that are not good for us, one good thing has happened, good therapeutic interventions have come to the fore. In spite of expanding epidemiology of non-communicable diseases, particularly diabetes, because we are talking about that, management is becoming better with the passing of the day. So people manage to live longer in spite of diseases. It is not only the general longevity has increased, but it is also increased for diabetic population, right? And specific data initially used to be, as you very aptly said, from 18 to 60. But now that people are aware, a huge market is emerging in elderly people, a geriatric group. And diabetes steeply increases beyond 60th birthday as well. If you look at the graphs of our own studies also, you will find out that diabetes escalating right from the second degree and certainly even takes an upward skew in the 60s, 70s and 80s. So that, and this presence of diabetes in that age group also impacts the prognosis of concurrent comorbid conditions in that old age. Like many of them happen to be incidentally hypertensive for a long time and now they have diabetes. Many of them simultaneously have been having a stable coronary artery disease or a coronary artery disease where an intervention has happened, now developing diabetes. Many of them having problems with cognition, many of them having problems with bones, many of them having problems with joints. Like, simple, we ask someone, take a walk, change your lifestyle, walk more. Now, certainly a person is moribund who has had a bilateral knee replacement. It's very difficult. Or osteoarthritis who cannot afford a replacement. So this question becomes mute. It's very difficult.
Yeah.
So that's why, the specific focus on this age group. Because as you are growing, the whole body is also growing and some of the tissues are progressively withering away, caving in.
So, whatever you have said, means do you prefer a class of drug in these elderly people, because as you said, we have to avoid all these risk factors, means side effects of the drug. Do you have any class of drug in your mind when you start medication?
I must tell you, there was a decade-long data in the United States about emergency admissions and hospital admissions. And I was really amazed to know one of the important reasons for hospitalization, even in United States emergencies, is hypoglycemia.
Yeah.
And a current data I was reviewing, 44% of these people were 65 or above. And an old person cannot tolerate hypoglycemia well. As a professional, when a person has hypoglycemia, he can have hyperadrenergic symptoms, catecholamines go up and throws a rhythm disturbance. Or there is severe tachycardia and throws a myocardial infarction. A stable coronary artery becomes an acute event, right? Or certainly, there is a problem with autonomic nervous system. He does not throw any of these symptoms and straightway goes into a lack of glucose into his nervous system, neuroglycopenia. One fine morning is found unconscious, is found in the bed, has already had a hypoglycemia for hours together. When somebody notices in the morning, is living the rest of his life as a vegetable because of the neuroglycopenia. So probably one of the most important things that needs to be kept in mind is that you need to give drugs that have a minimum possibility of giving hypoglycemia.
Yes, because even one episode of a hypoglycemia in an elderly is a deterrent for him. Means he is afraid of taking the medicines next time because he remembers this, and it creates a cycle where he has a hypoglycemia, he starts to eat more and he keeps a lot of sugar by his bedside. So eventually he lands
The whole
up in
process
trouble.
gets undone again.
Yes. And the second point is concern is orthostatic hypotension. Means we have to be select a drug where hypotension doesn't occur.
Absolutely. So people would prefer a drug that has a relatively minimum chance of giving hypoglycemia. If you look at endocrine diabetes practice for the last half a century, predominantly we have been using sulfonylureas and insulin. And probably some of the highest rates of hypoglycemias have been with these two classes of drugs. But they have their own prowess also in a requisite population. But now for more than 1 decade, we have an experience with a new class of drug known as gliptins. These gliptins have been shown to have a relatively far less propensity to give hypoglycemia, far less propensity to give orthostatic hypotension, as you very aptly right now said. So this seems to be emerging as an important class of drug in the elderly people. In the past, huge data was not available. While I was reviewing some recent information for this today's talk in this particular conference, now I was really amazed. There's a huge data emerging on many of those molecules in elderly people, because now the industry has realized that they have a potential specifically in this segment of population as well. I saw quite a few papers where people have tried to compare sitagliptin's efficacy and safety profile in people who are less than 65, 65 and 75, 75 and above, and found them reasonably efficacious. And looking at the safety profile being pretty good. I found the similar data on all wilder gliptin. I found quite few papers on that, looking at that. And there was one meta-analysis which was comparing, different age groups and looking at whatever treatment people have been taking in the past. Sulfonylurea insulin, gliptin and insulin. The prevalence of hypoglycemia in gliptin class was far lesser. So again says it has an edge in that population. The third, when you look at a guy at 75, you don't have to be as stringent in a hemoglobin A1C as you will be at 45. So this is another inkling that has come to the fore in the recent years. So you can live with a relatively more relaxed hemoglobin A1C. A hemoglobin A1C at 7.5 might be acceptable, which may not be acceptable at 45. Yeah. So all these things are done to sanitize that management does not complicate issues rather than helping issues.
One more point is that do you think that gliptins means now we see that the CKD is increasing? They can be relatively used more in this class of group, in CKD patients.
If you look at all the gliptins today, gliptins can be used, but dose modification is advised. Probably the only drug, 80 to 80% of the drug gliptin is usually taken care of by a non-kidney route, right? But two drugs that have been seen not to take this route predominantly, linagliptin and some softer data available with enagliptin. So if you do proper permutation in combination with the dose that all of us do once we see a patient in front of us, even in that group, it can be adjusted accordingly.
Yes. Now we see that initially we had we were not using gliptins much because of the price constraint. Now I think as the patent is off and they have become cheaper, do you think these drugs will be overtaking sulfonylureas, or they will be used more than SUs as a first line of drug?
I must tell you, initially when we started talking about gliptins in the subcontinent, that was in 2007. I was a bit skeptical given the cost of the molecule. But if you see how the market has shaped in the last 3-4 years, a huge class of patients are getting shifted to gliptins and metformin. Gliptins, metformin and insulin. In fact, this reminds me of a very important meta-analysis that was published rather recently. All cardiovascular outcome trials, millions and millions of rupees spent on that to prove the cardiovascular safety of different drugs, including gliptins. But what I was looking at this meta-analysis, people looking at cardiovascular safety, because this is another aspect that we need to be very careful.
Yes, nowadays you cannot introduce
in elderly people in particular.
Yeah.
In elderly people in particular, as we alluded to in our earlier discussion, might have collateral risk factors for coronary artery disease, invariably will have collateral risk factors. What they did in this meta-analysis, a huge amount of population, elderly people 65 and above, who one class who were on, if you look at conventional practice that you and me have been doing for a long time, somebody is on metformin, then we escalate it to metformin, sulfonylurea, then it doesn't work, we'll give him insulin. Now there's a huge data bank available on these people. Now in the current half a decade, what is happening now? People are on sulfonylurea and then gliptin, as you just know by alluding to. Many times people will be say sitagliptin 50 milligrams, 1 gram metformin twice a day, and then you add insulin. In the older age group, 65 and above, because you're scared of that hypoglycemia.
Yeah.
You will give an insulin that has a lesser chance of giving hypoglycemia, blah, blah. And this data, retrospective data, analyzed, and they again found out there was a huge difference in cardiovascular mortality and morbidity and acute events in people who were on insulin and sulfonylurea versus insulin and gliptins in favor of gliptins. So again, another major point that probably, this class is achieving a relevance and importance in that age group. I think across the board, across all the age groups, this class has become quite popular in the recent half a decade. And as very aptly said, in this part of the world, in a communicable, non-communicable disease being a lifelong issue, cost was always been an important issue.
Yes, sir.
It's always lucrative to talk about a great molecule in a classroom, in a talk. But when in real-time practice you look at it, you need to look at the feasibility of execution of a management protocol or a prescription on day-to-day basis, and it has to be doable.
Yes, I think in the algorithm which has been given by ADA and ESD on the treatment protocol, one corner is that if cost is an issue, you can use SU. Do you think that is going to change? If cost is an issue, you can even use Gliptin now?
Oh, absolutely, because the if is for the cost.
Yes.
If you remove that if and the cost, then obviously you know where the choices would be. It is something like, for ages we have been using N-page insulin. For ages we have been using regular insulin, right? And now if suddenly, a basal insulin which gives you a minimum hypoglycemia, or no hypoglycemia, theoretically assume no hypoglycemia, but it's 10 times costlier. So the 10 times cost inhibitors.
Yes.
But tomorrow you tell us it is at the same cost.
Yes. Because
it will be inappropriate practice if you do not prefer that drug.
Because ideally when we are selecting a diabetic drug, our aim is that it should not increase weight, there should be no hypoglycemia. Third is it should be cardio safe.
Absolutely, absolutely. So all these factors, if you take into consideration in conclusion, probably many of these concerns are addressed if a gliptin is used in an older age group, provided it brings the hemoglobin A1C to the level where you want it to be. Not that you let it be at 9.5 and say it's okay, just because you are giving a drug.
Is the efficacy of gliptins as good as SUs in a reduction of HbA1c? How much is the difference?
No, there's a significant difference. You see, if you look at global data, most of the gliptins have been shown to give a HbA1c of a reduction of 0.6, 0.8, 0.9. But our experience in the country has been that a lot of data shows in Indians, a hemoglobin A1c reduction of 0.8 to 1.2.
Okay.
But powerful, potent sulfonylureas can do far more than that on an average basis, but at a cost, and that cost is hypoglycemia.
And that's a dreadful...
and that is something that you specifically avoid in that age group that you were talking about.
Thank you, Dr. Zargar. I think now we have a clear opinion. That means if you have an elderly patient and you want to select an oral anti-diabetic, so you have to be careful, taking into point that the drug should not cause hypoglycemia, it should not cause postural hypertension, and it should be effective. Thank you, Dr. Zargar.
Pleasure.
Thank you.